Howdy. Good morning. Aaron Boster here from the Boster Center for Multiple Sclerosis. Super excited to be kicking off the last live stream of this calendar year. It's December 20th. Gorgeous but a little chilly Saturday here in Ohio. I'll be turning my camera on and taking your questions live at the top of the hour at 11 a.m. I'll look forward to seeing you then. In the meantime, get yourself comfy and cozy. Welcome. Grab a beverage. I'll talk with you soon. Folks are starting to roll in. We've got our moderator, Joe Siders, in the house. Thank you for being here, good sir. Zamim is in the house. Welcome. Carrie Perry, representing Indiana. Welcome. Great to see you. George Musa in Sydney. Good morning, everyone. Moscow representing. Mohammed is in Moscow. That's amazing. We've got Joe de Coates from Portugal. That's fantastic. Welcome, everyone. Kansas City is in the house. Welcome, Andrew Bruce. It's great to see everyone today. I'm going to mute my mic and be in the background getting some things set up. We're going to, of course, turn my camera on at the top of the hour at 11 a.m., where I'll be answering your questions live. This is an Ask Me Anything MS, the very last one of this calendar year. Hello, howdy, hi. Good morning, everyone. Aaron Boster here from the Boster Center for Multiple Sclerosis. Super excited to be kicking off this December Ask Me Anything live stream, literally the last live stream of this calendar year. We're going to go live at the top of the hour at 11 a.m. Eastern Standard Time, where I'll be fielding your questions live. Until then, please say hi to your neighbor. As you jump online, share where you're jumping on from. It's always amazing to go back through the chat after it ends to see where this growing global online village has amassed. It's really, really cool for me. Welcome, everyone. Thank you for being here. If you see someone in blue, that's a moderator. Thank them for helping keep everything smooth and easygoing. I'll talk to you in a few. I'm getting things set up in the background. Very excited to kick it off here in 25 short minutes. Testing, 1, 2, 3, 4. Mary had a little lamb. Over. Can you guys hear me okay? Checking on my sound. Let me know in the chat if you can hear the sound okay. Welcome to the neighborhood, saying all clear. Fantastic. STMHF, thank you very much. Joe Sider's giving me a big thumbs up. Love seeing that. Thank you, sir. Hey, Phil, great to see you. Thanks for being here. Donna's in the house. Welcome, welcome. Hunt and Fishing family, thank you very much. Welcome, Brian. Welcome, Melissa. Hey, Keith, thanks for being here. Good morning, everyone. Aaron Boster here. Very excited to kick off our last Ask Me Anything live stream of the 2025 calendar year. We'll turn the cameras on and I'll start taking your questions live at the top of the hour. 19 short minutes. As you jump online, please share where you're jumping on from. It's awesome to go back through the chat and see where everyone has amassed from. Pennsylvania is in the house. Ottawa is in the house. What's going on, Carrie? Delaware representing. What's your weather like in Delaware right now? Where in Germany are you, Benny? Or Benny's mom, 4639. Joe Siders is reminding us, if you click that link that he provided, you can sign up for the Boster Corner, which is a free monthly newsletter sharing the latest and greatest of what's going down at the Boster Center for Multiple Sclerosis and Single Point Healthcare. You can find out about research opportunities, and you can find out whenever I go live online. And so feel free to sign up for that if you like. It's completely free to sign up. You can cancel anytime, and you'll get a monthly update on what's going on. West Germany, close to Dartmouth. Thanks, Benny's mom. CBD for sleep, I hear ya. Close to Cologne. Well, I'm really appreciative that you're here today. The weather in Columbus, it's chilly out. The snow's mostly melted. It's pretty cold out. I'm not sure it's freezing any longer. What's your weather like? Hello from Mexico City. Great. This is amazing. Middle of Georgia, upper 50s. That sounds really nice, to be honest with you. DJ, where in vacation are you? New Hampshire, it's a little chilly. I hear that. That's all right, George. We're glad that you're here. Tennessee is in the house. What's going on? Chicago warming up. Chicago's not terribly warm this time of year. Missouri's in the house. What's going on? Muskingum, Michigan is representing. Massachusetts, what's shaking, Paul? Vancouver representing. Florida's in the house. What's your weather like down in Florida? Got Missouri rocking and rolling. Love those hearts, guys. Thank you. Fork UMS is in the house. Mr. Ekman, it's great to see you, my friend. Thanks for being here. Robert's one of our amazing moderators 4QMS actually is a fantastic YouTube channel with some really great recipes. So feel free to check his YouTube channel out, 4QMS. Sweden is in the house. That's phenomenal. Slow burn, where in Sweden are you? ATL is in the house. Chattanooga representing. This is amazing. Welcome, everyone. Welcome, welcome. Aaron Boster here. Gearing up to kick off an Ask Me Anything live stream at the top of the hour in 12 short minutes or 14 short minutes. Oh no, it's barely going to hit 80 in Florida. Haha. We wish. Oh, Connie, that's really nice of you to say. I'll look forward to it as well. There's 81 of you that have already jumped online. That's phenomenal. Thank you. Orion Grip, that's a great question. We can field that question when we go live. Good morning, everyone. Aaron Boster here. Getting things set up in the background to tackle your MS questions at the top of the hour. We've been doing these monthly live streams since 2020. When we opened up the Boster Center for MS. It's the highlight of my month. I look forward to it every month. So excited to get a chance to connect with you guys, kick it just a little bit, and answer your questions. Dubai is in the house. Thanks for being here, my friend. Penny Stone, thank you for being here. Welcome, welcome. High fives all around. Joe's reminding you that you can help by clicking that thumbs up button. Showing a like teaches the YouTube algorithm that you dig this content and helps me push it out so more families impacted by MS can benefit. Hearts do the exact same thing, guys. Show love. I really do appreciate it. Robert's in the house. What's going on, my friend in Syracuse? As you jump online, share where you're jumping on from. We've got Missouri in the house. We've got Syracuse, New York representing. Man, somebody is showing massive love with the hearts. Thank you for that. That's super awesome. Middle Tennessee is in the house. What's going on, Cassie? Great to see you. Thank you for being here. Dublin, Ohio. What's going on? Robert Wilhelm, it's great to see you, my friend. Sri Lanka's in the house. That's on my bucket list. I would love to visit Sri Lanka at some point. Thank you for being here, everyone. There's 90 of you that have jumped online, helping me get ready to kick it off at the top of the hour. We're going to be fielding your questions live in this last Ask Me Anything of the calendar year, 2025. Mr. Bell was in the house. What's going on, fella? Nice to visit family in ATL this time of year. Your weather's probably better than back home. Where in California are you? We've got Wales representing. I have had a decent amount of coffee already. No worries whatsoever. Well, I'm glad to have you here, Cassie. Thanks for being with us today. We're going to go live in 10 short minutes. I'm going to step away from the microphone, take a quick bio break, get ourselves ready to rock and roll. As you jump online, make sure to tell us where you're jumping on from. It's great to see where everybody has amassed. In this growing global online village, I'll be answering your questions for a solid hour, starting at the top of the hour in 9 short minutes. I'll be right back. Say hi to your neighbor and grab some water. I'm back, and we are 6 minutes out before we go live. Doug Tag is online, OG of the channel, hopefully with coffee in hand. Good morning, everyone. Windsor representing. Great to see you. Thank you for being here. Vink, I would wait a little bit. I'm going to turn my camera on and I'll start to field your questions in 5 short minutes. Hunting and fishing family, great question. We'll field that in just a few. This is Aaron Boster from the Boster Center for MS and Single Point Healthcare. Super excited to be here with you today, which will be our very last Ask Me Anything live stream of this calendar year, 2025. There's 99 of you that have jumped online to help me kick this live stream off. I'm so happy that you're here. Thank you for being here. We've got Melissa from Long Island in the house. What's going on, lady? Thank you for being here. Alec Electric is asking some great questions. Keep those questions at the ready. I'm going to be turning my camera on in 5 short minutes. Now, when it gets to be just a few minutes out, I'm going to ask you guys to flame up the chat and let the YouTube algorithm know that you are here and super pumped to participate in this live stream. It helps teach that algorithm that this is good stuff and push it out so more families impacted by MS can find this channel and hopefully up their game. So we'll start the flames in just a minute or so. Brandon Bieber is in the house. What's going on, my friend? Dr. Bieber is an MS neurologist par excellence out in sunny California and Los Angeles. He's got an amazing YouTube channel. If you don't know about him, you're missing something. So definitely check Dr. Bieber out. Brandon, thank you for being here. I hope you and yours are doing well, and happy Hanukkah, my friend. We've got 4 minutes until we go live. It's just about time to start flaming up the chat. So if you're new here, just before we go live, we like to show a little flame love. And so let's try to flame up that chat. You know how we do it? Show some love. If everyone on the chat would throw flames in the chat, that would be fantastic. Paige has got the right idea. That's exactly right. Janine's got it figured out. Paige, show us what to do. Go ahead and flame up that entire chat. We'll just have a couple minutes of flames right before we kick it off and go live. Hunt's got the right idea. Vin's got the right idea. Lord, ça c'est super. Merci bien. Go ahead, Paula. Rock and roll. Zen, thank you very much. Polly, thank you very much. 33, Flutter by. We're killing it. Entropy's Embrace. That's a great title. Joe Sider is leading the way as always. Mini on cam, what's shaking? Mr. Bell is in the house showing much love. Thank you for being here, guys. We're going to turn the camera on in 2 minutes. We've got 2 minutes to rock and roll and show some fire in the chat. Go ahead and flame that up for me, guys. Heck yeah, Minnie. All right, Paula. Dr. Bieber's even doing it. Thanks, partner. Look at Dr. Bieber leading the way. That's so awesome. Thank you, guys. 2 minutes until we kick it off and I flip that camera on. I'm so pumped to be here with you today. It's December 20th. This is the very last live stream of this calendar year. That's amazing to me. I'm so excited for you guys to be here with me. There's 110 of you that have jumped online. That's phenomenal. Thank you. If you haven't shared where you're jumping on from, you can share when we turn the camera on. But right now, it's all about flames. Throw some flames in the chat, guys. Show us how you do it. Thank you, Paige. Thank you, Angela, one of our amazing moderators. We're going to turn the camera on in 1 minute. Don't stop the flames, guys. We have less than 60 seconds to fill the chat up with flames. Don't stop that music. Don't stop the magic. That's phenomenal. Literally counting down the seconds until we turn the camera on and get this party started. There are drum rolls in the background. We've got flames in the chat. Staring at that clock as it kicks down to 11 a.m. sharp. Don't stop those flames, guys. I'm loving it. Hey! Good morning, everyone. Aaron Boster here. 11 o'clock sharp on a crisp December 20th, Saturday. I am so happy to be here with you all today. My name's Aaron Boster, the founder of the Boster Center for Multiple Sclerosis, a single-point healthcare company where we're caring for families impacted by MS from around the globe. We started doing these live streams, back 5 years ago when we first launched the Boster Center. And more or less, we've done one live stream every month. This is a great opportunity. It's something I look forward to each and every month, getting to connect with you and being able to field your questions live. As you jump online, please share where you're jumping on from. I love to go back through the chat and look at this growing global online village. It really warms my heart to see where everyone's visiting from. So please make sure to do that. As you share questions, please keep in mind that I don't have enough information to diagnose or treat you on the interwebs. We need to make sure that the questions asked are generalizable so that everybody can benefit, because I can't give you medical advice over the internet like this, but I can educate, empower, and energize, which is absolutely what I hope to do. So without any further ado, thank you for being here. There's 122 of you that have jumped online. That's amazing. And let's start things off by taking our first question. We've got the Netherlands in the house. We've got Saudi Arabia in the house. We've got Florida in the house, Canada. There's people from everywhere. That is amazing. Thank you, all of you. Let's try to find that first question in the chat. Ireland is representing, one of my favorite countries to visit on Earth. And I'm waiting for, here's a question. All right, so first question we'll tackle is from Paige LaRosa 30, who writes, I get pretty frequent, like once a month, severe eye pain, like an optic neuritis. 3 days or so, and then it's gone. Can this come and go like this? My doctor says it's not a flare, also says it's not my MS. So, first of all, that sounds yucky. I'm sorry that's happening to you. So she's describing that about once a month, she gets a really bad pain behind her eye that lasts for a couple of days and then goes away. And I can understand why that would make you think about optic neuritis. So optic neuritis is a situation where the immune system attacks the nerve that runs the eyeball. That's called the optic nerve. And it makes that nerve swell. So two bad things happen. One, light doesn't get through the optic nerve, so you can't see, and you end up losing vision. Two, because the nerve is swollen and it's encased in a bony canal, when you move your eye, it tugs on that nerve and it hurts like the dickens. And so two of the hallmark features clinically of optic neuritis is a decrease in vision, blurred vision or loss of vision in some capacity, and pain, specifically with extraocular movements. When you have head pain, any kind of head pain, the brain itself doesn't have pain receptors. So the brain, like the physical meat of the brain, doesn't hurt. The coverings of the brain have pain receptors, and there's a lot of pain receptors behind the eye, which is relevant because if somebody has almost any kind of headache, you can have retroorbital pain. So when I hear about recurrent pain for a couple days once a month, I don't think about optic neuritis. I agree that that would be a very unusual thing to have happen recurrently like that. But I do think about other types of head pain, like, for example, there's migraines which happen to go line up perfectly triggered by a menstrual cycle. We have a fancy neurology term, catamenial migraines. That's a Scrabble word, which means I have a migraine that's kicked off with my menstrual cycle. So once a month, it may trigger a migraine, and that could manifest as pain behind the eye. So the good news is that can be treated. And so there's a lot of opportunities to treat pain like that. At first blush, I can understand why the neurologist thinks it might be separate from your MS. But no matter what is the underlying cause, that sounds horrible, and I don't want you to feel that way. And so I hope that we can find some medicines to try to treat it. I imagine that we might use two different kinds of medicines. We might use a medicine that you take in the background to prevent that eye pain from occurring. And then we also might use a second medicine when the eye pain occurs to try to put the kibosh on it. Thanks for sharing that story with us, and best of luck. I hope your eye feels better. Our next question comes from Slowburn 451. Is there a minimum number of oligoclonal bands required in the spinal fluid to meet the diagnostic criteria for dissemination in time in MS? That's a great question. And there's actually a lot to unpack here. So the first thing that I want to share is that we don't have a singular test, like a lab test, to diagnose multiple sclerosis. I really wish we did, because that would make my job much more straightforward, but that's not the case. What we have instead is a set of diagnostic criteria, and those criteria have different elements to them, and they're very good. And so we can apply the criteria to a human being and turn the crank and kind of see whether or not they meet the criteria for multiple sclerosis. One of the things that we can look at is the clinical presentation. One of the things we look at is the neurological examination. One of the things we look at is the neuroimaging. We look at spinal fluid if it's obtained. And then lastly, we need to prove that it's nothing else. So those are like the 5 elements to an MS diagnosis. And spinal fluid is not required to make the diagnosis, but there are situations where a positive spinal fluid would tip us over the edge, where it would make it positive. And so I think the most recent diagnostic criteria update, which we've talked about on this channel not that long ago, the 2024 revised criteria made some updates to the spinal fluid. So to answer your question, when you draw spinal fluid in 2025, soon to be 2026, you draw spinal fluid and then you draw blood, and you're going to do a comparison of the antibody production because you're trying to figure out if there's an excessive production of antibodies in the central compartment, in the spinal fluid. And one of the ways that we do that, which is part of your question, is we count what's called bands or oligoclonal bands. And we're looking to see if you have an excessive number of bands in the spinal fluid that are not seen in the bloodstream. And typically 2 unpaired bands is the cutoff for most laboratories. You want to look at the lab because different labs are a little bit different. But generally speaking, if you have 2 bands that are in the spinal fluid that are not in the bloodstream, then we would consider that to be positive or supportive of MS. But there's a new test which has also been adopted, a spinal fluid test, called kappa light chains. So when you think about an antibody, which is a protein, it's made up of different parts, different chains. And part of it's called the light chain, the kappa light chain. And if you have a lot of antibodies in the spinal fluid, some of those parts of the antibodies will slough off and you'll have little antibody parts floating around and you can measure them. And so if you have an elevation of the kappa light chain in the CSF, that is another indication that you have excessive antibodies, and that would also count towards an MS diagnosis. So is it necessary for most people to have a spinal tap? I don't think so. A lot of times, looking at their story, their exam, and their imaging, we're able to make the diagnosis. I would submit that maybe 1 out of 10 of my patients benefit from a spinal tap when we're trying to clarify things. Great question. Let's take the next one. This question is from, and I'm going to pronounce your name wrong and I apologize, Muskin Zara. I hope I didn't butcher that horribly. It's a great question. If the symptoms of aggressive MS get totally reversed, and the patient does very well after Plex, after 6 infusions, can Ocrevus be stopped? If not, what would be the consequences? So I really like this question, and I think there's a lot to try to understand here. Here we have a situation where someone's telling us that they have aggressive multiple sclerosis. So what does it mean to have aggressive multiple sclerosis? The most common definitions of aggressive MS involve very frequent attacks that don't fully recover, that are very close together. So like attack after attack after attack without full recovery. Definitions would also include very active MRIs, where the MRI has contrast-enhancing lesions. Definition would also include a progression that's of disability that's very, very fast. So someone who, for example, is starting to need an assist device in the first couple years of their disease. These are working definitions of aggressive multiple sclerosis. So we have someone who doesn't have easy breezy cover girl MS, they're having very active inflammatory disease. And then they have pheresis or Plex. Now what is Plex? Plex or plasma exchange is not a medicine, it's a procedure. And it's a procedure where we basically clean the blood. So when you have a Plex procedure, they typically put in very special IVs, not normal ones. They put them here, or sometimes they have to put them up in your neck or in your chest. And they hook you up to this giant machine, which pulls your red blood cells out, runs them through a filter, and then puts them back in your body. And that filter pulls out large molecules like antibodies, like your autoantibodies. So when someone with MS has a severe MS attack, and we give them steroids and they don't recover, they've got about a 50 or 60% chance of making a meaningful recovery if we do Plex. So do we do Plex often? No, we don't do it often. It typically needs to be done in the hospital, and it needs to be done with specially trained nurses that know how to do this procedure. And it needs to be done where there's access to a blood bank in case there's a problem and we need to give blood. Now, the procedure takes several hours, so you typically sit in a hospital bed or in an infusion chair, and they hook you up to this machine, and they filter your blood for a couple hours, and they put it back. And then they skip a day, so if we did the Plex on Monday, on Tuesday, we're not going to do anything. And the reason we don't do anything is we're giving time for more autoantibodies to be produced and then to go out and circulate in the bloodstream. So we take a day off on Tuesday. Then on Wednesday, we do our second Plex. And you do Plex every other day, typically for 5 to 7 exchanges, which means you're typically in the hospital for 10 to 14 days, so basically 2 weeks. And again, we do Plex when people are having a very aggressive attack and they're not fully recovering. Sometimes they can make a very meaningful recovery. And when we look at the question, the person had aggressive MS, I'm assuming they had an attack, I'm assuming they didn't respond to steroids, and then fortunately after 6 exchanges, they got better. So then the question is, well, if they got better on Plex, do they need to be on Ocrevus? Ocrevus is an example of a disease-modifying therapy. Ocrevus is intended to prevent future bad events, to prevent attacks. When you have an attack, we need to treat that attack. And my point that I'm driving at here is these are separate lanes. We need a medicine to slow down the MS, a disease-modifying therapy. In this question, that answer is Ocrevus. We also need to give medicines to hasten recovery when someone has an attack. And these are separate medicines. The way I would think about things is, I'm delighted that you made a recovery after Plex. I'm very upset that you had an attack at all. And if you had an attack while on Ocrevus, we have to ask the question, is Ocrevus adequate? Is it doing the best job possible? We would likely make a decision to either A, continue on Ocrevus with a zero tolerance policy, meaning that was the only time it was allowed to mess up, and if it messes up again, we're going to have to switch, or we may make a switch now. Either way, we do need a disease-modifying therapy because the way that we used the Plex was to hasten recovery from an MS attack. Now, before we move on to a different topic, it is interesting that in some centers, like my good friend Bhupinder Khatri in Milwaukee, they will do plasma exchange about once a month in some of their progressive patients because there's some literature that suggests this might be a helpful tool for progressive disease. It's not approved for this indication, and it's very, very hard to get it set up, but it can help some patients. So Plex is interesting stuff, and I think that's a great question. Thanks for asking about it. I'm going to change things up, and we're going to look at the river scene. And let's take the next question from the chat. All right, let's take a look here. So here's a question from Janine, who writes, "Hi, Dr. Boster. Well, hello. Do you think Ocrevus is as effective as Mavenclad, cladribine?" No, I don't. I think it's more effective than cladribine in groups of people. Now, let's break this down. So when we think about MS disease-modifying therapies and we think about the efficacy of these medicines, it bears mentioning that most of the medicines have never ever been compared. So for example, there's never been a study that I'm aware of where MS patients were subjected to either Ocrevus or Mavenclad in a Pepsi Coke challenge to see which one's better, right? I don't think that's ever been done. And so when we weigh in on questions of efficacy, we're really kind of sharing our opinions. Now, maybe that's a fair thing to ask me because I've used a lot of Mavenclad and I used a lot of Ocrevus and I've done trials in Mavenclad and I've done trials in Ocrevus. So maybe I'm in a position to share my impressions. When I think about MS in groups of people, I think Ocrevus is more effective. When I look at the data and its ability to slow disability over a long term, to decrease attacks, to help the MRI, I think Ocrevus is probably superior to Mavenclad in groups. However, individual humans are not groups. Individual humans are individual people. And for an individual, a drug either worked or didn't. The point that I'm getting at here is I have patients that we put on Ocrevus, and they do well for a while, and then they have some breakthrough. And in some of those patients, we've then put them on Mavenclad, and they've done really well. Why? Probably because they're completely different mechanisms of action. They do different things. So before we leave the question, let's talk a little bit about what those different things are. The way Mavenclad works and the way Ocrevus works are categorically different. Now, they both, interestingly, impact the B cells, all right, which is a sliver of the immune response, part of the humoral immune response, but they do it in a different fashion. The way that Ocrevus works is it identifies adult B cells and murders them. So you have no adult B cells floating around. Because you have no adult B cells, they're not around to piss off the T cell to get it mad enough to attack you. See, the T cell is what does most of the battle royale. But the T cell can't attack your brain and spinal cord unless the B cells get it co-stimulated, riled up enough that it can attack. So by removing the B cells, the T cell can get in your brain and see your brain and think it's a bad guy and want to attack it, but it can't because it can't get upset enough. And so that's the way that Ocrevus works. And when you take repeated courses of Ocrevus, you're suppressing and constantly keeping the B cells down. So they are constantly never available, so they can't get your T cells mad at you to attack you. Someone wrote in the chat, is this basically rituximab? Yes, it's the same mechanism as rituximab. Rituximab, Ocrevus, Kesimpta, and Briumvi are all B cell depleters, all basically doing the same thing by suppressing B cells. That's different than what Mavenclad does. So Mavenclad doesn't suppress your B cells chronically, it reboots your B cells. Mavenclad has a very small impact on T cells, but I mean like really small, like not that much to speak of at all. The biggest impact that we see in Mavenclad is with the B cells, B as in boy, or B as in bone marrow, which is why they're called B cells, because they're born and they grow up in your bone marrow. And your B cells in the setting of MS are naughty. And so what we do when we take Mavenclad is we drop them down and then we make them come back, but when they come back more well-behaved. So unlike Ocrevus, Mavenclad is not chronically suppressing your immune system. It's dipping the cells down and right back up. I sort of envision if you're driving on the freeway 80 and you pump your brakes twice, now you're going 60, all right? You decreased. But what you're doing with Mavenclad is neater than that because you're rebooting the way the cells behave. For example, when you have MS, you tend to have very few regulatory B cells. You don't have enough COPs. And when you have MS, you tend to have an excessive amount of inflammatory B cells, a lot of robbers. When you take Mavenclad, both go down, and what happens when they come back is you only have a few robbers and a bunch of COPs come back. So you've changed the behavior of those cells so they're not so sassy McSasserson from Sassy Town. My point here is they work differently. That was a great question. Thanks for asking it. All right, let's take another question from the chat. So Terry says something very nice here. She says, love the fact that you spend your time with all of us. So needed. Well, thank you. I have this belief that I help you by request. So as an MS neurologist, I help you by asking you to do things. So let's think about this for a second. I'm not a surgeon. So surgeons help people by knocking you out, cutting you open, removing bad things, and then sewing you back up expertly, right? And then you wake up, and then you're better because the bad thing that happened is now no longer there. A surgeon doesn't help you by request. They go in and they do something. I'm not a surgeon. I literally help you because I ask you if you would please consider X, Y, and Z. And if I understand something, but I'm not able to convey it to you, I might as well not understand it. Because just because I know that, for example, smoking speeds up your MS, that doesn't help you. And if I say to you, hey, you shouldn't smoke, you're going to show me your middle finger, right? You're going to say no. But if instead I educate you on why I don't want you to smoke, because I explain that smoking is very pro-inflammatory to your blood vessels and to your lungs, but also to your brain, and it speeds up MS disease activity. And so you can get worse faster by smoking. If I teach you that, if I educate you, then you understand why I'm asking you to do something and you're more likely to do it. The reason I'm saying all this is I don't know how I can help up your game unless I spend some time educating you, right? So I created this YouTube channel to do that, to help educate and also to empower people and energize people. And I wanted to create a resource that I thought was valid. And so I think I'm telling you the truth, so I don't mind referring you to me. So it's very nice of you to say that. And it's my hope that families impacted by MS could find answers to questions that they're searching for here. So Bird D3Q asks, what's a safe DMT if I have a low white blood cell count? I am on Copaxone now, but I don't like the dents in my skin. And so this is a great question about disease-modifying therapies because all medicines come with side effects, and we're trying to match the benefits of the medicine and the side effects of the medicine to the right person and the right situation. And there's a bit of an art to that. So some of the MS medicines work by suppressing the immune system, by dampening or pushing down the immune system. And the white blood cells are the immune system. So if you already have a really low white blood cell count, you can imagine you might not want to take an immunosuppressant that would push it down further. And that's what I assume they're saying here. So the way I interpret that question is, hey, I need something that's not an immunosuppressant. I need something that's not going to suppress my immune system because I've got a low white blood cell count. And that is absolutely something that we can do with disease-modifying therapies. So let's list some options which will not lower your white blood cell count. So Copaxone will not, and you're on Copaxone and you're having some welts or some divots, and that's not very nice, but it won't lower your white blood cell count. Now, the interferon products rarely lower your white blood cell count. Most of the time, they do not. So these would be things like Avonex, Plegridy, Rebif, Betaseron, Extavia, those medicines, the interferon beta products. Very rarely they can lower the white blood cell count, but they're not supposed to, and they generally don't. So they would be an option. Then there's several immunomodulatory pills that you can take. So for example, Tecfidera, dimethylfumarate, is a pill twice a day. That does not lower your white blood cell count, except rarely. About 1 in 5 patients have a side effect where it lowers, but you can easily check that just by looking at the white count the first couple months while you're on the drug. And then there's a Me Too drug, Vumerity, which is kind of like new Tecfidera, if you will. That's diroximel fumarate. It also does not drop your white count unless there's that rare side effect. So those are medicines that you could take if you didn't want to risk immunosuppressing yourself. What else could you do? Well, you could do Aubagio. So Aubagio, or generic Arava, the prodrug, these are medicines that do not drop the white count. Now, they make the white blood cells not rapidly reproduce, so they're modulating the behavior of the white blood cells, but they don't drop the white blood cell count. So if someone was immunosuppressed, we would be able to consider Aubagio. What else could we consider? Well, interestingly, the S1P1 receptor modulators could be used, but it would be a little tricky. Let me explain. When you take an S1P1 receptor modulator, so this would be like Gilenya or the newer drugs that have come out, the Me Too drugs, so like Ponvory or Mayzent or Zeposia. These are pills which cause 80% of your white blood cells to get trapped in your lymph nodes. So if you put 80% of the white blood cells in the lymph nodes, then they can't circulate through the bloodstream. And if they can't circulate in the bloodstream, they can't cross the blood-brain barrier into your brain. So it's sequestering the cells in the lymph nodes. And you could do that because it doesn't suppress the immune system, but it would look like it suppressed the immune system. Because if you take 80% of the lymphocytes and you put them in the lymph nodes, and then you stick a needle in the bloodstream and draw blood, the number is going to look really low. And so you could do that, but it might make things complex because it would make it hard to follow that. So we probably wouldn't run out to do that, all things considered. What I would caution doing would be using the B cell depleters because they could make your white blood cell count go down. I would caution using Mavenclad for the same reason. I would caution using Limtrada for the same reason. So some thoughts, but my point is there's a lot of options out there of things that we could do that won't suppress the immune response. Great question. All right, let's switch up the scene, and here's a great question. And I don't know that I can pronounce your name correctly. I want to say like Scion, but that can't be right. Scion. All right, well, howdy. This nice person's question is, hi, Dr. Boster. Please can you explain the concept of a drug holiday? Is this a good call for amantadine and baclofen? And does that keep it effective without having to increase the dosage? All right, so this is a very good question. So first off, do not do a drug holiday unless you've talked to your doctor about that drug specifically for you, right? So nobody listening to me right now should like take this information and then go run over to their medicine chest and start doing drug holidays, because certain drugs you never want to do a drug holiday with, and certain drugs you might. And that's something that I want you to game out with your neurologist or with your doctor. That's very, very important. So one drug that we do not do a drug holiday with is a disease-modifying therapy. I generally don't want to take a drug holiday from your DMT because I want that in your system helping you keep MS boring. There are other drugs that are symptomatic therapies. And so you've listed a couple in the chat, symptomatic therapy. So baclofen is a symptomatic therapy. And baclofen helps, it's a muscle relaxant, helps with spasticity. You also listed amantadine. And amantadine is a drug that was invented for lots of weird reasons, but we use it off-label in MS for energy for some patients. And I would not recommend doing a drug holiday for those drugs. Those are not drugs that I typically do a drug holiday for. I have not found people to develop much of a tolerance to baclofen or to amantadine. That's not been my experience. And those are not drugs that I use a drug holiday on. What drugs do I use a drug holiday on? On stimulant medicines. So in MS, we deal with fatigue a lot. A lot of people have fatigue in MS. And in MS, we deal with cog fog quite a bit, where you're just fuzzy in your thinking and having trouble. And it turns out that taking a stimulant medicine can trick the brain into being more awake and more attentive, and it can help you remember better. It can help you attend better, and it can help your cognition. So these are medicines that we use a lot in MS. I don't think this qualifies for the MS Water Challenge because it's iced tea, but what the heck, let's do it anyways. It's a delicious iced tea, and I am thirsty, so MS Water Challenge, yo, when I drink, you drink. That's really good. So tell me in the chat if you think I'm cheating because I'm doing the MS Water Challenge with iced tea this morning. When you take a stimulant medicine to trick your brain to be more awake and attentive, that can be a huge game changer for a lot of my patients. However, much to my chagrin, if you take a stimulant every single day, after weeks or months, it'll wear off and it wanes in its benefit because your body acclimates to it. So what I have found to be very helpful with my patients with stimulants, things like Adderall, Ritalin, Vyvanse, Provigil, Nuvigil, stuff like that, is I have them take a drug holiday where they take a day off or 2 days off once a week. So a hypothetical lazy Wednesday or lazy Sunday. They don't take it that day, and that way it resets. And that's something that I do very routinely with the stimulants, but those are amongst some of the only medicines I do that with. So that's a great question. Thank you for asking it. And of course, make sure that you're talking to your doctor so that we're not experimenting with medicines without their help and supervision. So Phil says that I am cheating if I drink this instead of water, but he says it's okay because he likes to use carbonated water. I love carbonated water. All right, let's take another question from the chat. So
Tammy Anderson writes, I have MS and AFib. Can I take a stimulant for fatigue? So that's a really great question because it's a very real situation. In the real world, sometimes nature's too generous. And you can have MS and you can also have AFib. So the question is, if you take a stimulant, is that bad for the AFib? And that's something that you'd want to talk to the cardiologist about. I have patients that have MS with fatigue and they have AFib, and yes, they can take a stimulant, but I've gamed that out with their cardiologist to make sure that I'm not making their heart rate run too fast and things like that. So it's definitely not a no, it's a let's check with your doctors. All right, let's take another question. So Julie writes, hi, Doc. Howdy. Thank you for these live chats. Well, you're welcome. My question is, can neck pain, not Lermite's, be caused by new lesions on the side of your neck? So she's asking, if you have new neck pain, could that be an MS thing? And it would be very rare. Generally speaking, when there's damage to the spinal cord, it does not manifest as neck pain. Now, humans can have neck pain for lots and lots of different reasons. But no, hearing that, that's not my immediate thought that that would be related. All right, let's take another question, and I'm going to change the scene up just for fun. Here's a great question. So this is a question from Liz, which is probably on the mind of many of us. She writes, can you talk about tolobrutinib trials for PPMS, please? What can people with PPMS be hopeful for? So Liz is talking about a trial that I was intimately involved in, or I am intimately involved in, a trial called the Perseus trial. The sponsor of the trial is a manufacturer named Sanofi. And they're studying a drug, which is a BTK inhibitor called tolobrutinib. And I didn't make up that word. And they studied tolobrutinib in relapsing MS in two trials called the Gemini trials, which we participated in at the Boster Center. And they didn't work. So tolobrutinib was not successful for relapsing MS. Then they studied it in a trial called the Hercules trial in secondary progressive MS, and we participated in that trial, and it did work. And so tolobrutinib was successful in slowing progression in secondary progressive MS. And that information has gone to the American FDA, and the FDA was supposed to weigh in September, and then they said, we need more time. And so they decided they were going to weigh in this week, and they decided, no, we need more time. So we're going to finally hear the answer from our government, from the FDA, probably in the first quarter of next year. And we anticipate that tolobrutinib will get approved for secondary progressive MS. Meanwhile, there's a third set of trials for tolobrutinib studying primary progressive MS. And we're involved in that trial as well. That trial is called the Perseus trial. So you see the theme of Greek mythology here. And in the Perseus trial, we enrolled patients with primary progressive MS, and they either took tolobrutinib or they took a placebo, dummy drug. And we just got a readout, and it was negative, which sucks. And that's really, really sad and makes me bummed out. And it's particularly sad because it worked in secondary progressive MS. Many of us, myself included, were very encouraged that it would work in primary progressive MS, and it didn't. Now, we have not seen any of the data, just the top line, just the negative result. And so I don't have information yet on any of the specifics. Now, the question asked was, what can we be hopeful for? And there's actually a lot that you can be hopeful for. I'll give you an example. There's a different BTK inhibitor called fenobrutinib. So again, I didn't make up these words. Fenobrutinib is a different BTK inhibitor made by a different manufacturer, Roche. And fenobrutinib was studied in relapsing MS in two trials, which the Boster Center is involved in. In one of the two trials, it worked, and the other one we don't know yet. It was studied in primary progressive MS, fenobrutinib, and it was studied in primary progressive MS against Ocrevus, the only drug that's been approved for PPMS. And this trial was called the Fentrepid trial. So in the Fentrepid trial, people with PPMS either took BTK or they took Ocrevus. And the trial was positive. They were able to show that the BTK wasn't any worse than the Ocrevus. They didn't prove that one was better than the other. They proved that one was not worse than the other. It's called a non-inferiority trial. That's a very long-winded way of telling you that we have a new positive trial for a PPMS drug. It's not Perseus and tolobrutinib, it's fenebrutinib in the Fentrepid trial, but that's very exciting. Another thing that I think you have to be hopeful for is the fact that with our new revised McDonald criteria, we're calling in a scripture that MS is one biologic disease, whether it presents with progression or relapses. And if you follow the logic out, it's going to open doors for us to reconsider drugs which were previously only tested or only explored in relapsing MS to be applied in PPMS. And that is something to be very excited about. Great question. Thank you for bringing that up. Here's a question from Walter who writes, I'm wondering what's your opinion on the use of creatine in MS? I've heard it's supposed to help with cognition. I use it daily anyways because I work out a lot. Just curious about your opinion. So I think creatine is safe, and that's very important. I also think that it has some of the best data for energy. So sometimes I'll have patients take creatine to help with energy levels. Many people use it when they're working out because it helps with recovery, it helps put on muscle and stuff like that, but it helps a lot with energy. And so I think that it's a fair thing to try. Creatine is processed by your kidneys, and unless you have really bad kidney function, it shouldn't be too much of a problem taking that. Whenever you take a supplement, I think it's a best practice to let your doctor know. Just say, hey, FYI, I've started this supplement, just so they can write it down in case there's a drug interaction, something that they can help you think about. So Benny's mom is being really kind and says, hey, everybody, remember to hit the like button. And that really does help out this channel. Now, when I started the channel 10 years ago, I just wanted to make videos to help my patients up their game and so that I could educate them between visits. I see people typically every 3 to 6 months, and so I thought, well, gosh, that's a long time between visit A and visit B. So if I can make a video on a topic, then that would be a really great thing to do. And it has, over the last decade, morphed into something much bigger than that. It's a big part of my life. I'm really, really appreciative of you guys. And I love helping educate and empower and energize and put out content. And when you hit the like button, that's super helpful because it teaches the YouTube algorithm that this is valuable content. And so if enough people hit the like button, YouTube then pushes the content out farther so that more people can find the channel and more people can benefit. And I think that's really great. So thank you for those that are doing that. Thank you for Joe Siders reminding us that you can click that link and sign up for the Boster Corner, which is a free monthly newsletter that we put out, sharing the latest and greatest at Single Point Healthcare at the Boster Center for MS, all the research that we're doing and things that you might choose to participate in, and whenever we go live. So it'll tell you about the time and date and locations when I go live throughout the month so that you can find me if you want to ask me questions or interact. All right. So I'm not going to be able to pronounce your name correctly. Oh no, Anders asks, injection with Botox, what's your opinion? So Botox is pretty interesting stuff. It's the most poisonous, toxic substance on earth, I think, or amongst them. And used in very, very, very small amounts, it can be like really, really helpful for lots of things that happen in MS. So one thing that Botox can be very helpful for is it can help with headaches, with migraines. So people impacted by MS are at high risk of developing migraines, way higher than the general population. And so we end up treating a lot of migraines at the Boster Center for Multiple Sclerosis. And getting Botox for your migraines is a really, really effective way of knocking them out. Getting Botox takes less than 5 minutes. There's special, we go poke, 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 poke. There's a couple different places that we inject. And you'll then have excellent migraine control for 3 or 4 months even sometimes. So that's pretty cool. So we use it for that a lot, and I think that's really helpful. I also like it because a lot of the medicines for migraines have side effects. So if we do Botox, then oftentimes you don't need those medicines. Another thing that we use Botox for is spasticity. So MS damage to the brain and spinal cord can cause your muscles to misbehave and not get along very well. So when your muscles are trying to do this, they're also trying to do that. And then you end up with a tug of war across your own limb. And you can have spasms, cramps, charley horses, stiff arms and legs, yucky stuff. And we can use lots of different lotions and potions to help with spasticity. But Botox is one of my faves because if you have spasticity of your wrist, let's say right here, then you don't want to take baclofen all day just to help there because the baclofen is going to go everywhere. If we shoot this with Botox, we can relax it, and it only works here. It doesn't work anywhere else. So when you're dealing with focal spasticity, a focal treatment is the bee's knees, it's to the jam. And Botox is an excellent focal treatment. So I think that Botox has a lot of really excellent uses in the setting of managing MS. One other area where it can be used, but it takes a master to do it, I do not have the skill subset to do it, is you can use Botox off-label to treat MS hug. So when you're having an MS hug, what's happening is the muscles between your ribs are clamping down. Your spinal cord is telling them to contract, and you're literally like squeezing yourself, and it hurts like the dickens. And it's caused by the rib meat, the muscles between your ribs clamping down. So if you imagine that my fingers are ribs, the muscles in here clamp down. So you can Botox that, where you can go in and you can Botox the muscles and get them to relax. You need a master Botoxer to do it because if they put the needle in too far, they can drop your lung. So that would be an immediate hospitalization. So I don't feel like I have the skill subset to do that, but I do have Botoxers here in town, some of my colleagues that I used to work with that are masters of doing that. So that's another indication or use for Botox. That was a great question. All right, here's a question from Robin Blankenship who writes, Dr. Boster, if a PPMS patient has already had breast cancer twice, just finishing their treatments, they won't take Ocrevus because of that. So let's talk about this. Ocrevus does not cause breast cancer. So that's been proven. When we studied Ocrevus 10 some years ago, there was a question about whether it might cause breast cancer. And so that was very, very concerning because most people with MS have breasts. And fortunately, it turns out that's not true. So Ocrevus does not increase the risk of breast cancer. And I have many patients who are breast cancer survivors, and we've worked with their oncologists who are completely comfortable, and we put them on Ocrevus. The second thing I would say is, if you suffered breast cancer and had a mastectomy and no longer have breast tissue, you could go on Ocrevus even if it did cause breast cancer because you don't have breasts to be at risk. So, given that the only currently FDA-approved therapy for PPMS is Ocrevus, I would challenge why you haven't gone on it, and I would talk in detail with your oncologist. Because when I've spoken to oncologists about risks of breast cancer, and we talk about Ocrevus, oftentimes they will remind me that rituximab, which is the parent compound, is used to treat breast cancer. So I think that it's worth exploring, and I think it's a great question. Thank you for asking it. All right, let's take one more question. Oh yeah, Shay brings up a really important point. Another use of Botox that I forgot, shame on me, and thank you for reminding us, Shay, is bladder Botox. So your bladder is a bag of muscle, it holds urine, and in the setting of MS, it can spasm down to the size of like a racquetball. So then, you drink half a Coke and it's full and you're sprinting to the bathroom and sometimes can't make it in time. So if the urologist snakes a tube up the hoo-ha into your bladder, they can Botox the inside of the bladder and they can get the bladder to relax to a normal size. That can be amazing. And it's another really, really good use of Botox. So that's an excellent one. I forgot about that. All right, guys. We've been rocking and rolling for 45 minutes, and I'm going to put a cap on this last live stream of the 2025 calendar year. I want to thank all of you for taking time out of your Saturday to connect with me, and thank you for your questions. My name is Aaron Boster, founder of the Boster Center for MS, a member of Single Point Healthcare, and really proud to get to deliver MS care in my hometown. I'm really lucky that I get to do this. I'm very blessed. I've got a great team, and my patients are very dear to me. So thank you to each and every one of you for spending time with me this year. Thanks for going on this journey with us as we try to make MS boring and try to educate, empower, and energize families impacted by MS. We're not going to stop doing this. We're going to keep on keeping on, and I will continue to put out YouTube videos every other Monday morning, and I'll continue to do these live streams as long as you guys keep signing on. So with that, I'm going to wish you a happy and healthy end to your year. Hug and kiss your family. They're very dear, and I'll see you in 2026. Take care.